Dr. Fadi? Okay, our next speaker will be Professor Muhammad Fadil. Professor Fadil, you are ready, sir?
Yes, my friend.
Dr. Fadi is sharing. Can you please stop your share, Dr. Fadi? Yes, please. Dr. Fadil, you can share, please, your presentation, sir. Our next speaker will be Professor Muhammad Fadil. Professor Fadil will speak about Perthes disease, Elizarov principles, when and how. Please, sir.
Is it okay now?
Yes, sir.
Thank you. Bismillah ar-Rahman ar-Rahim. I am pleased and honored to be here with you, with my professor, Professor Osama Higazi, my mentor. White hands for myself and many of our colleagues, as mentioned by my dear friend, Professor Muhammad Al-Ashhab. Also, it is a chance to appreciate the effort of Dr. Muhammad Al-Ashhab for all this activity, which enlightened many days since Corona days. Actually, alhamdulillah, that we have in touch with you and with other friends, especially with our friends and colleagues, and also as a chance to talk and keep in touch with our seniors, as this honor to share and see my professor and mentor, Professor Osama Higazi. My talk is about Perthes disease, the Elizarov principle, when and how. So when and how is the target of our talk, to use the Elizarov principles. My best wishes for our beloved, the Egyptian Orthopedic Association, and for all our members of more than maybe 7,000 members. I am happy to be one of these elegant and honored association. This is the Al-Mini University Hospital, my place of work, 240 kilometers south to Cairo. And as a start, we can say that Perthes disease represents one of the most challenging pediatric hip problems. I am lucky that I come after this panorama and this marvelous decision-making system that had been presented by Professor Osama Higazi. It was a very talented presentation, actually, and helped me so much to go through directly so as not to waste time in explaining what about Perthes disease for other etiologies and other modalities of treatment, and go it through directly in these minutes that permitted by Professor Al-Ashhab. Perthes disease was described more than 100 years. It is relatively common to some extent in childhood, affecting 0.8 per 100,000 children, but the etiology of the disease has not been established, as mentioned by Professor Osama, and there is no consensus on the optimal treatment. A story about Perthes. This is Nono Lopez, one of those pioneers about arthrodiastasis that had been started long time ago, maybe last I think 1999, I think, or 1990, in Portugal, and we met in Goa in Assami meeting, and we was discussing about his interest about this diastasis. This was, I think, 2008. Yes, it is in India, yes, in Goa. I am honored also to share my dear professor and mentor, Professor Khamis Deeb, in one of his favorite subject, which is modified Salter's innominate osteotomy in the treatment of Persis disease in 2009 in the Pan-Arab Orthopedic Association, I think, or the Egyptian Orthopedic Association. Also, he have a great job in this etiology, and I was lucky enough also to have to share him with my dear friend Professor Gamal Husni and Muhammad Lakluk, and this was in another publication in Clinical Orthopedic and related research. So one of our target this presentation is when to do Elizarov principles in Persis disease and how to do it in these few minutes. Late onset of Persis diseases is that our target in arthrodissesis mainly is our target mainly to talk about those below the age of 8 and associated with some head at risk signs and such as those of some sort of lateralization or even cyst or something like this, signs of head at risk. Out of these, we are not going through the age below 8 years, but we are dealing directly so as not to frustrate ourselves in the many research dealing with this, to talk about late onset Persis disease older than 8 years of age, which constitute about 20%. It is a good number to deal with late Persis disease of cases, and is known for its aggressive course, poor outcome with chronic hip pain and stiffness. So for late onset of Persis disease older than 8 years of age, arthrodissesis of the hip joint was used and recommended by many authors to tackle this issue. It is a one target, one principle, and different tools had been used to treat this, and different techniques and also different constructs. So arthrodissesis is well known as to stretch out through the joint, whatever the joint. The arthrodiastasis means to stretch through joints. It had been known in ankle arthritis to make arthrodissesis of the ankle joint, in the elbow joint in cases of stiff joints, as mentioned before, and maybe also in many cases of stiffness of the knee, and have marvelous effect there. So the concept of hip arthrodissesis referred to ourselves as a distraction hysteresis. This theory of some authors consider to be that hip distraction in Persis disease unloads the joint. We know that the joint is in need for unloading. So also, this unloading negates the harmful effect of the stress on the articular surface, especially in the stage of revascularization, as we know, which may promote the sound healing of this area of necrosis. So if we can offload the joint in the process of revascularization, we can have a very nice containment and contained head if we negate these stresses, as we will see in this vicious circle. So the distraction hysteresis have also a microvascular effect, which applied by the tension along the soft tissue surrounding the hip joint during distraction stimulate the microangiogenesis. Microangiogenesis is one of the most important things to revascularize the head. This vicious circle, which is started by anywhere, the trauma, subchondral fracture, collapse, secondary ischemic episodes, and obliteration of the vasculature channel, ischemic episodes, osteonecrosis, and the stage of revascularization as mentioned by our Professor Osama Kaz. This revascularization stage here, if we can offload and prevent this trauma to vicious the circle again and stop it here, we can, this revascularization can be occur, keeping the size of the head without the secondary ischemic episodes due to secondary trauma, and this vicious circle could be interrupted by the arthrodiastasis. This is one theory of the microvascular effect and the mechanical one related to the Elizarov principles of distraction osteogenesis. Another one is that offloading. It looks like simply the bed rest and the ambulation prevention of pampillatory as braces had been mentioned by Professor Samah Ghazi. So this is a mechanical effect which offload this pressure. So creating a space between bony surfaces, minimizing mechanical stress, restoring synovial circulation, fibrous repair of the defect of the articular cartilage, intact and congruent femoral head will be issued later on. So if we have this head and we didn't leave it to be compressed by this wood bearing, if we offload it, we can give it the chance for healing for a great percentage of success. So the theory of Elizarov or principles or arthrodiastasis, whatever the apparatus will be used, either unilateral, bilateral, or Elizarov circular frame, whatever, the arthrodiastasis may help in these by two theories. During this management technique, different complications issue. It is not bread and butter. It is not all are very nice and simple and could be they work simply, but some patients develop pen tract infection, which not controlled by local dressing and antibiotic. This leading or losing and the pen replacing in some cases. This cases of implant failure, this cause implant failure or stress fracture may occur in some of these Schanz screw. So in many instances, this dismantling or this disruption of the apparatus may lead to adjustment of the frame sessions every now and then because of the loss of fixation of one or more pins, contamination, containment of the hip joint may be lost due to this loosening. If we didn't follow up well the containment and leave Elizarov apparatus to work by itself without follow up, we can find that the head extruded from its containment method, and so it is not a correct process of containment. So we should take care of containment all over the process of Elizarov application. The loss of the mobility of the hip joint in some instances need manipulation under general anesthesia, and this also, if we are doing manipulation under general anesthesia, in many instances we are in need for adjustment of the frame again. So this rose the need for more knowledge about its indication as arthrodiastasis, the tool or the apparatus that will be used, the construct, the technique, and the complication, especially frame readjustment, and more research is needed. Kandal started this research in 1993 by many cases at that time. It was not for persons only. Persons disease constitutes just 3 cases, DDH in 2, tuberculous affection of the hip joints, chondrolysis in 1, epiphysiolysis. So it was taken apart in all salvage procedures of these conditions, and he used hinged in a monoplanar fixator. Kokaoglu used it in 1999 and used Elizarov frame in 11 cases in pairs. Another Kokakaya also used it in 2000s, and in this case, he has different etiology. 8 cases in pairs, post-traumatic in 2, and the DDH again in 1. He used in his cases Elizarov frame with articulated distraction. He used this articulation and distraction, not straight, and it is a hinge type of Elizarov frame. Maxwell, one of very good papers in 2004, used a hinged monolateral external fixture. Also another authors in 2007 used monolateral external fixation, articulated distraction. And Ali and Amin also articulated distraction for Pears's disease itself. Nowadays, Pears's as itself alone had been used, arthrodersthesis had been used in cases of Pears's disease only. Dr. Abdurrahman Amir, rahmatullah alayh, and our friends, Dr. Ashraf Khafour, also present also a very good paper, and I am honored to share Professor Gamal Hosni, Professor Adib, and Professor Lakluk in 2011 in clinical orthopedic and related research, and also another one had been presented by Lakluk and Hosni. So also continuous talking about these techniques had been elaborated, but in all, still we have in many cases pen tract infection, loosening, pen replacing conditions, and the implant failure, and sometimes stress fractures. And adjustment of the frame stress these conditions. So we are in need to more idea to safeguard against these drawbacks, especially augmentation and looking for the other way of our lecture, which is when, I think we know now to some extent when we will use arthrodersthesis in Pears's disease, and now we will look for how to do it. The problem of it is that use of non-hinged distraction or articulated joint distraction or hinge technique. For non-hinged distraction, such as circular frame or even articulated joint distraction by monolateral with fixation of the joint, there is no more problems about using distraction without hinges. But the problem started by using hinges. Up to the best of our knowledge, there is no comparative study between the effect of articulated versus non-articulated joint distraction in Pears's disease. So the problem started in using articulation of the joint distraction by hinge technique as monolateral hinge replacement. Placement is the basic component. We should put it exactly, and the monolateral external fixator or the circular external fixator, the hinge placement is crucial site, as we will see here. It should be in line or collinear with the center of the head of the femur. So it is the hinge is lateral to the center of the hip joint. This lateralization depends too much according to the size of the thigh. So we may likely to have a slim patient, or if we have a huge thigh, so this means that the center of rotation or the hinge will be away, and we are going for what is for a thigh such like this. It is not like slim like this. So going away from it, make this hinge and this articulation going to a stress that make the pins up and down, doing a cantilever effect, which is not important. It is an important issue to prevent loosening, especially in the cancellous bone of the suprastabular pin, not in the femoral. So this loosening starts by starting a movement. And this starting a movement, if we go away by the center of the hinge, we will have a cantilever effect of the chance of the suprastapler, especially suprastapler, and also the hinge will be away from this center of rotation. And this is, in our opinion, one of the main cause of loosening. Looking for something of cantilever effect in the biomechanics or something like this, it is exhaustive to go through it. But the problem is that we are going to use for the hip joint a joint in one direction, flexion extension in cases of Elizarov, not as the function of the hip joint, which is, as we know, ball and socket joint. It is not such like femur or like ankle to do arthrodiastasis without many complications. So the problem, in our opinion, is that the joint or the hip joint in need for a special issue. So we are obliged to take care of loosening of these conditions. So mechanically and biologically, we obliged the hip joint to behave as one way or a hinge joint, although it is a ball and socket joint. We are going through this again in a hurry. To go for what is we recommend is to use a double hinged, multi-axial, multi-level fixation, not simple like this one. It may be works well also, but according to the size of the patient or the age of the patient. But looking for this, we should take care of that we use double hinged, not one hinge. This is hinge here, and another one go inside more, and also to use mini fixation in the axis, and also multi-axial in the longitudinal one. So we have a transverse, or we can call it sagittal fixation, and also parallel one here, and double hinge to support this by this near to some extent to the skin and musculature may help to lessen the effect of cantilever effect and may keep the suprastapler chances, which is crucial, in place for a long time. So the aim of this study, it was to highlight the rational approach of treatments that aim to prevent the decrease and the occurrence of previously mentioned complications, especially that of loosening and readjustment of the frame. Looking for the adjustment, whatever the adjuvant procedures, either we will use Elizarov or we'll use non-articulated arthrodiastasis, or using percutaneous or adductor tenotomy or something of epithelial drilling and some ideas. Generally speaking, in a hurry, the placement of arthrodiastasis start after some notes I would like to present it. Pin placement, which may be supraacetabular area and iliac wings or both, and the femur may be subtrochanteric or the femoral diaphysis. According to the size of the patient, the center of the hinge should be in the center or collinear with the center, and should we have, even if it is monolateral fixator and even it is Elizarov, we should have a proper positioning to allow flexion extension before going out of the operating theater, and the positioning of the patient is so important. Also, this is also the stop. If you couldn't stop it, pain will exaggerate the night and prevent him from sleep. And to do distraction, many options about this, from the second day to start or the third post-operative day, to do it 0.2 to 25 turn or 4 times a day or 1 turn a day until Shenton line overcorrected by 1 up to 2 or 4 up to 5 millimeters. removal of the fixator, timing of formulation after formation of the lateral pillar is preferred. Under anesthesia is recommended to do some gentle manipulation, and the operative technique in a hurry, lateral or
Much time, sir,
supine
please.
table.
الوقت يا دكتور فاضل بيه بعد اذن حضرتك.
انا سالتك عشان كده ببص في الساعه كل شويه، انت قلت لي 25 دقيقه.
لا 15 يا فندم. لا كان كده 15.
لا مكتوبه.
لا 15 يا فندم.
طيب خلاص، لا ده انا قاريها 25 عشان كده، ده انا زودت وكنت
لا
قاطع،
15
ده
يا
انا
فندم. 15
زودت كل ده زودته. لا انا قريتها 25، انا اسف بقى. فزودت يعني هذا، يعني دي حتى لو العنوان اسمه summary. I will go in a hurry. This is the components. This is intraoperative connections. I'm so sorry for misunderstand this message from you.
العفو يا فندم.
لا الله يخليك. I try to extend it after I find it. Guide wires. This is 2 hinges, as we see. Application, no problem for this. We will go for this to be sure that it is good and collinear with each other, and this is simply go for directly to the center of the head. We will go in a hurry. This is also all this. I increase the slides after knowing this. We will go for this. This is important. If we note that the collinearity of both hinges may give me the view as it is one hinge, not 2 hinge. And also, it is so difficult to achieve this free movement, flexion extension, even in a monolateral frame. So we shouldn't go out of the operating theater without achieving this. So this is our opinion about this multi-level, multi-distraction and the message. This is some cases that had been presented before. This is a clinical case. Post-operative. Another cases. As a conclusion, I would like to go for the conclusion. In case of Perthes diseases in selected group of patients, if the arthrodesis is indicated where poor results are expected from conventional treatment, it is not in a simple or a possibility of have a conventional surgery. If there is out of conventional surgery, or we suspect that the result is it is not acceptable, hip distraction by Elizarov external flexor is a reliable management procedures for decreasing the post-operative loosening and the frame modification, which is a very bad complications of Elizarov in arthrodesis. A double-hinged, double or multi-axial, multi-level option of Elizarov application is a method of treatment. Thank you.
Thank you so much, sir. شكرا جزيلا أستاذنا الفاضل. متشكرين يا فندم. We will move to the next.
I repeat my apology because
العفو يا فندم. العفو يا
I
فندم.
misunderstand your
شكرا على
message.
المحاضرة الممتعة يا فندم.
Actually,
شكرا يا أستاذ.
I prepared it for just 10 minutes.
Thank you so much, sir.
I'm so sorry.
أمتعتنا
But
يا
I read
أستاذنا.
the message. الله يبارك فيك. شكرا جزيلا.
Our next
And
speaker
thank you that you give me the note. كويس انك قلت لي، نبهتني يعني.
شكرا جزيلا يا أستاذ. شكرا جزيلا يا أستاذ. Our next speaker will be Professor Mahmoud Al-Rusasi. Professor Al-Rusasi will speak about the outcome of closed reduction of late presenting DDH. Professor Al-Rusasi, thank you so much for joining us, sir.
Excellent. Excellent.
السلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته يا فندم.
شكرا دكتور أشهب و congratulations for this excellent organization and the execution of this magnificent meeting. I'm honored to present my talk about the outcome and the predictors of successful closed reduction of late presented DDH in children under the age of 3 years.
ممكن تخليها فول سكرين يا دكتور محمود.
Yes, sir.
تمام
Yeah.
كده
Full screen.
جميل.
اتفضل يا
Okay.
فندم.
لا جميل، تسلم.
I am Mahmoud Rosasi, professor of orthopedic surgery, Tanta University. The problem of DDH in developing country is that we do not have a routine neonatal screening for DDH. That's why the children usually present late after walking, usually after the age of 1 year, sometimes older than this. And so we have a very long waiting list in the university hospitals waiting for surgery. On the other hand, surgery for DDH is fraught with several complications. The amongst or the most important is avascular necrosis and proximal femoral growth disturbance, which is almost a variably inevitable consequence of any treatment approach, whether conservative or surgical. A literature review revealed several published articles on a large series about the closed reduction of DDH in children under up to the age of 3 years, and several authors have attempted the closed reduction in children and they reported spontaneous improvement of the acetabulum after closed reduction. This comes in contrary to the statement of Salter that he said that after the age of 18 months, the remodeling of the acetabulum is not sufficient, and pelvic osteotomy is a must if we are willing to have a well-developed acetabulum. A very interesting literature review about the closed reduction for developmental dysplasia of the hip. Most authors reported a success rate more than 90%. About 9% of the hips failed reduction. The development of AVN in cases treated by closed reduction ranged around 25%. And interestingly, in a published study about the effect of hip abduction on the development of AVN, they found that by MRI studies post-closed reduction, they found that up to 60 degrees of abduction did not affect the perfusion of the femoral head. That's why it is necessary to establish a definitive success and the complication rates for following closed reduction for DDH. Actually, this will hasten the sequence or the treatment of the cases of DDH, and the surgery would be reserved only for the non-reducible hips. We, in the past 6 years, we have performed a prospective study which included about 30 children who had DDH and diagnosed after the age of 1 year. Bilateral dislocation was present in about 18 cases. So we had 36 hips and unilateral hips on 12 cases, a total of 48 hips. The children aged from 9 to 26 months at the time of our treatment. We treated only idiopathic DDH, and we excluded the teratologic and the paralytic cases. The method of reduction or closed reduction of the hip, the procedure was performed under general anesthesia. Percutaneous adductor tenotomy was performed. We can see here this child on the left side is dislocated. We can see the limitation of abduction of the hip and the prominent adductor tendons. We did percutaneous release of the abductor tendons, and under image intensifier, the gentle closed reduction was performed by pulling the femur and then abduction with gentle pressure on the greater trochanter to relocate the femoral head. And very important to avoid excessive abduction of the hip. At this point, we will be faced by one of three scenarios. The first scenario is the hip which is reducible and stable. Then we will proceed with closed reduction. The other two scenarios, the hip may be reducible but unstable. Then there must be a hinder or the very deficient acetabulum. And the third scenario is the hip which is not reducible. After adductor tenotomy, we try closed reduction, but does not reduce. Then if the hip is reducible but unstable or not reducible, then we will proceed for open reduction in a standard manner. If the hip is reducible and stable, then we will check the reduction under image intensifier. We do not do arthrography. The image intensifier and testing the abduction, the reduction manually is enough in most cases. And then we apply the human spica, the hip spica, bilateral hip spica in the human position, which is flexion 90 degrees, abduction up to 60 degrees, and external rotation. We do post-reduction CT scan to ensure the good reduction and the containment of the head within the acetabulum. The post-operative immobilization, we adopt the 3x3 protocol. 3 months, total of 3 months immobilization. The first 3 months in a hip spica, continuous. And the second 3 months, we use a rigid hip abduction brace, 23 hours per day for 3 months. The third 3 months, the rigid hip abduction brace is used by night time only and removed by daytime to allow the child mobilization and to stand up and walk. And this is a case of left hip dislocation in a child. She was 20 months old at that age. We did abductor tenotomy, closed reduction. Please notice here in the immediate post-reduction X-ray how the acetabulum was dysplastic, and in the following X-rays and the follow-up, you can see here the development of the acetabulum and the formation and the maintained reduction. And this is a child at the age of 6 years. The femoral head is well developed, no evidence of AVN. The acetabulum is developed very nicely, and the excellent range of motion of the hip joint. We were successful to reduce the hip closed in 87%, almost 88% of cases. In 5 cases, closed reduction was possible but unstable. The hip reducible but unstable, then we converted to open reduction. Redislocation after 1 week occurred in 1 case, and AVN occurred in about 14 cases. AVN of variable degrees, about 29%. The predictors of successful closed reduction, because this is very important in the initial counseling and discussion with the parents of the child. Are we going to do closed reduction and that's enough? Or we are going to try closed reduction, and if it failed, we will proceed to open reduction? This question, the answer to this question is very important. And the predictors of a successful closed reduction in our experience have been: first, a low station head, like in this case. High dislocated hip is more liable, is more prone to not to relocate easily. A well-developed acetabulum, like in this case, indicated by a good acetabulum index despite dysplastic, indicates predicts a good or successful closed reduction. Another important test is the telescoping test or pistoning test. Pistoning means you stabilize the pelvis and pull the femur up, and axial distraction and compression. In some cases, even while the child is awake, you can even relocate the hip. So if the telescoping test is positive, this means that there is a greater chance that the hip will be relocated. Another important point is the tight adductor muscles. If in examination you found the adductors are very tight, this means that if you do percutaneous adductor tenotomy, there is a greater chance that the hip will relocate. This is another case. A very important post-reduction X-ray sign we have noticed in our cases is the lateral ossification. Please notice here the red arrow pointing to the lateral ossification. We have seen this in the cases of successful closed reduction, and this is the first sign of the remodeling and the development of the acetabulum, and this indicates that closed reduction will be successful. We talked about the complication of closed reduction, the AVN and the proximal femoral growth disturbance. If the cases which had developed AVN, these are the cases who had residual dysplasia of the acetabulum. This child, we did closed reduction at the age of 20 months. Unfortunately, she developed there is an evidence of AVN. You can see here. 10 months post-operative and 3 years post-operative, we can see the evidence of AVN. The cases who developed AVN are the cases which failed to remodel or develop the acetabulum. And these children developed the residual acetabular dysplasia, like in this child, despite an excellent range of hip motion. The child walking very nicely, no limping. The head is reduced, but there is evidence of coxa magna, coxa brevia, and residual acetabular dysplasia. We inform the parents that if the child developed a residual acetabular dysplasia but maintained the hip reduction, then at the age of 4 to 5 years, we have to do an augmentation acetabuloplasty to prevent the development of premature osteoarthritis of the hip due to acetabular dysplasia. The augmentation acetabuloplasty, we do the normal modified Dega pelvic osteotomy, but instead of inserting small triangles of bone graft, we intentionally harvest a very long triangle and insert the part of the triangle inside the osteotomy and leave part of it outside like a shelf. So we call it the augmentation acetabuloplasty to contain or to cover the coxa magna or the large femoral head. From our study, the future directions and the research is going now in our department, we adopted the technique of closed capsule reduction plus or minus pelvic osteotomy. A closed capsule reduction is a very important concept because we have noticed that just opening the capsule of the hip joint is a risk factor for the development of AVN. We believe that the addition of iliopsoas release at the pelvic brim, preferably by endoscopy, would increase the number of the cases of successful closed reduction. That's why recently we are working on the arthroscopic assisted closed reduction of the hip, plus or minus pelvic osteotomy in cases of unstable reduction. For the cases of residual acetabular dysplasia, we recommend augmentation acetabuloplasty as I described. Formal open reduction should be reserved only for cases of non-reducible hips and teratologic dislocations. Thank you.
Thank you so much, Professor Mahmoud, for this very interesting talk. شكرا جزيلا أستاذنا. وهي يعني أنا قدامي على الكويستشن اند انسرز الدعوات لحضرتك يا دكتور محمود دي إن ربنا يبارك في حضرتك في علمك يا فندم.
الله يكرمك. الله يكرمك. شكرا جزيلا أشرف.
ربنا يبارك في حضرتك يا فندم. I don't see any questions, so I will have to move to the next speaker. Next speaker will be Professor Wael Nassar, Professor of Orthopedic Surgery and Shams University. Professor Wael will speak about pediatric sports hip problems. Professor Wael.
السلام عليكم جميعا.
عليكم السلام ورحمة الله وبركاته. أهلا دكتور البي.
كل الشكر طبعا للدكتور محمد الأشهب، وكل التحية للسادة الحضور على وقتهم وعلى اهتمامهم بالموضوع. يمكن أنا شكلي غريب شوية في وسط السيشن ده، لأن أنا أصلا السب سبيشاليتي بتاعتي سبورتس ميديسن، فأنا تمسكت بالسب سبيشاليتي بتاعتي رغم إن أنا موجود وسط كوكبة من أساتذة البيدياتريك أورثوبيدكس اللي هم نادرا ما بيتكلموا في حتة البيدياتريك هيب إنجرز. فقلت يمكن لما أكفر الموضوع ده يكون a little bit something different and something interesting for the audience يعني. طبعا مش هننسى اللي بيحصل دلوقتي لإخواننا في فلسطين، نسأل الله إن شاء الله يكتب لهم السلامة والنصر، ومن لم يشكر الناس لا يشكر الله. نحب طبعا نشكر الدكتور محمد الأشهب والزملاء على المجهود اللي عملوه في البرزنتيشن وفي التحضير لليوم ده. من أحب أن لا ينقطع عمله بعد موته فلينشر العلم. The spectrum that we'll be covering today is mainly that of the juvenile hip pain related to sports activities and sports injuries. Sometimes it's a reflection or the early diagnosis of a more serious hip problem, like one of the varieties that my previous colleagues talked about. And sometimes it's related purely to the injury at the field. All of us now notice that there is increasing interest in the parents and the children in joining sports in regular activities. What I usually give the name semi-professional athletes. Those are 10, 12, 14 years and are involved in everyday training and maybe involved in some of the national leagues and going to international competitions. So the hip pain is in such an age group. Sorry. Hip pain is common in adolescents and pre-adolescents that has a broad range of causes that range from benign to potentially devastating causes. Injuries to the hip and groin may account for up to a quarter of injuries seen in athletic children and may be acute or chronic, may be due to osseous causes, cartilaginous injuries, ligamentous injuries, muscular injuries, or different mixes of these injuries. Adolescent hip pain often strikes young athletes with structural abnormalities sooner than their less active counterparts due to the stress their level of activities places on the hip, which might otherwise present later or never. Sometimes children or pre-adolescents with mild form of Perthes or mild form of dysplasia never come to the orthopedic clinic, but once they start to participate in regular sports activities and sports training, they start to complain hip pain, which may be the first clue of a more serious problem they have in their hips. An occasional ache in the groin or hip may not be something about which parents or young athletes should be concerned, but chronic or repeated pain that does not improve should be evaluated by an orthopedic surgeon who sees hip problems on a daily basis. Also, the increased use of point-of-care ultrasound in orthopedic clinics has helped to provide timely and accurate diagnosis and some guided treatment measures. We have to take care and not to forget the differential diagnosis of hip pain, that it could be true hip pain or radiating or referred pain. If related to passive movement, especially in rotation, it's most probably related to hip pathology, but if not, all possibilities are equally valid. Sometimes it may be coming from the abdomen, may be coming from the back, may be coming from the inguinal lymph nodes, etc. Knee pathology that may be referred or presented as hip pain may be related most commonly to the patellofemoral problems, may be related to spine problems, may be related to non-orthopedic problems like appendicitis or iliac adenitis or inguinal lymphadenitis, colitis, pelvic inflammatory disease, complicated ovarian cyst. I have seen a couple of cases coming to my clinic complaining of hip pain, and they are, I was the third or fourth consultant they are coming to take the opinion of, and both of them, when I sent to my colleague for ultrasound examination, both of them are proved to be iliac lymphadenitis, which completely cleared after a short course of antibiotics systemically and anti-inflammatory locally. An increasing number of children are taking up sports activities and at more competitive levels. For this reason, radiologists should expect to receive greater number of requests from their orthopedic colleagues to image the athletic child who present with hip or groin pain. And as I mentioned before, developing the experience of ultrasound in the clinic is very important in cutting this dilemma short. The first item that we are going through is the transient synovitis, which may be a separate entity or may be the first step in a more serious disease like Perthes disease or slipped capital femoral epiphysis. It's a common cause of hip pain that causes limping and pain after sitting for a long time. It may be occasional self-limiting or the first red signal for a more serious problem like Perthes disease. So what to do with patient with presenting with pain, and ultrasound is coming with the diagnosis of transient synovitis. We just do the 3R. We do rest, we do reassurance, and we do repeated assessment, whether clinically or combined with ultrasound, which is better. Snapping hip syndrome is a term used to describe a cluster of symptoms that can develop when one of three possible scenarios occur. It may be something related to the tibial band that runs along the outside the leg from the hip to the knee, and proximal tibia, which snaps over the outside of the thigh, especially at the area of the greater trochanter. Or when the deep hip flexor muscle that forms part of the quadriceps snap over the front of the hip, or sometimes the iliopsoas. Lastly, when there are tears of the cartilage or labrum or fascia around the hip socket, and this may be the first clue that gives us the suggestion that the patient may have a minor form of phi or acetabular impingement. Muscle strains and or contusions or pulled muscle occurs when a muscle is overstretched or torn. In athletes, this type of injury is common in hip and groin area due to fatigue, overuse, or improper use of muscle. The failure to warm up before exercises also contribute to this problem, or let's say that non-professional trainers that deal with the young children are a very common cause of such injuries. Rectus femoris strain, which symptomize as a pain sharp in front of the hip in the groin, usually while it's doing some explosive activities like short sprinting. It's followed by swelling and bruising in some cases, with pain when lifting the knee up against resistance. It may be muscle injury or maybe avulsion injury from the acetabulum, unable to contract the muscle. If complete rupture has occurred, the lump may be felt due to recoil and building up of the proximal muscle. Strains or muscle injuries needs rest, stop the activities that cause pain, ice in the area for 20 minutes every 3 to 4 hours for 2 to 3 days, and re-evaluation. Take pain medication if needed for pain, over-the-counter medications such as ibuprofen, naproxen, selective COX-2 inhibitors if the age group allows, or acetaminophen can be used. In severe cases, stretch and strength of hip flexor muscles can be helped by the physiotherapy, by acting on the muscles surrounding the hip and supporting the area. Guide the patient in increasing activity level so they can return to former activities. We have very promising results for yearly use of PRP injection in the first 48 hours of injury. And this gives very good results because they stimulate formation of repair tissues to go to muscle bundles rather than fibrous tissue, and it gives good results in injury site and in returning to the pre-injury activity level. For cases of tears or ruptures, surgery may be deemed necessary in order to repair or attach the torn tendon. Also, some trials of PRP assistance of this repair or stem cells have a variable results. Here, the repair mainly is by osteosutures or suture anchor rather than by classic osteosynthesis. Hamstring is very important and very common. Tears, especially in those not having enough time for warming up, there is overstretching and there is pain, maybe in the back of the thigh, maybe in the back of the knee, maybe in the lower back. Hamstring injury is really rather common, but in most cases, the problem clears up quickly and the injured person is able to return to normal activities after a short period of rest. However, not all injuries are alike. There are situations where medical care and longer recovery periods are required. It can be primary or secondary or repeated. In primary cases, poor timing coordination in the hamstring during the switch between the leg recovery and initial leg approach, such as in the swing phase of sprinting, and lack of strength and stiffness in the hamstring during contact with the ground while running, and this is common in gumbaz and common in ألعاب القوى يعني. Secondary overstriding or pelvic control when running improper warm-up to prepare the hamstring muscles for force, inappropriate training loads such as high-speed work done late in the workup, fatigue, lower back problems, or playing on the surface that are slippery, which is very common in our playgrounds. This is the different image pictures of such injury, ultrasound pictures on the left side, MRI pictures on the right side. In the first picture, there is injury and the insertion. Second picture, injury in the muscle belly. And third picture, injury at the attachments, maybe avulsion, fracture. This is the classification of different hamstring strains, which may be at the myofascial level or musculotendinous level or intratendinous. Each one of these can be classified from 0 up to 4 degrees, which up to the 4th grade, which is the complete tear of muscle that may, in professional athletes or semi-professional athletes, require surgical intervention. Treatment according to the stage, with grade 1 mild pain and tightness, short period of rest, followed by gradual return to sports. Grade 2, there is pain, swelling, limp, tenderness, needs longer period of rest, which may be 2 to 3 weeks, with physiotherapy. Quadriceps, questionable rule of PRP injection, very beneficial if given early, useless if given after the 5th day. And there is gradual return to sports with protection. Kinesiotaping in the first 3 months after return to pre-injury activities is very important and very protective. Grade 3, there is severe injury, severe pain with swelling and ecchymosis, secondary inability to walk without aid. Surgical intervention may be required, as I told you, maybe by osteosuture or my suture ankle. Here, this osteitis pubis, which is the inflammation of the pubic symphysis, the joint of the two major pelvic bones at the front of the pelvic bone. The osteitis pubis is thought to be due to the repetitive pull of muscle over the front of hip joints. The condition is often seen in long-distance runners, soccer players, hockey players, and take long strides over prolonged periods of time. Stress fracture, very common, because it results from repetitive microtrauma over a period of time and may affect normal bone, which is fatigue fracture, or abnormal bone in the form of insufficiency fracture. In the context of sports injuries, fatigue fracture prevails, and up to 90% of these affects the lower extremities, especially the hip. Taking up a new sport and or suddenly increasing the intensity of sporting activity may be both predisposing to stress fracture, especially before a championship. This is picture MRI of stress fracture. Whatever you are in doubt or suspecting, please do MRI for this to exclude stress fracture, which may be, if misdiagnosed or may develop to classic fracture that warrants internal fixation. The diagnosis of stress fracture is important because if left untreated, athlete returns to sports activity before healing is complete. They may be progress to delayed union or even non-union and lead to significant morbidity. Stress fracture of the pubic rami are classic, seen in long-distance runners. MRI has sensitivity ranging from 96 to 100% and specificity of 100%, and therefore is the image of choice for such injuries. There is what's known as female athletic triad, which is amenorrhea, anxiety with osteomalacia, anxiety, amenorrhea, and osteomalacia. Sometimes anxiety is replaced by anorexia. There is decreased bone mineral density and is relatively common among young women participating in sports. The main goal of treatment of young female athletes with this triad is the natural return to menses as well as enhancement of bone mineral density. While no specific drug intervention has been known to consistently improve bone mineral density in this patient population, of course, vitamin D has a variable role, and there is valuable results in the literature about it. Maximizing energy availability and optimizing vitamin D and calcium intake are recommended. Iliac spine avulsions, the results from indirect trauma usually caused by sudden, forceful contraction of sartorius or tensor fasciae lata occurs during hip extension, sprinting or swinging in baseball bat. It may be anterior superior iliac spine or anterior inferior iliac spine. This is the picture of anterior superior iliac spine, which may be easily missed. This is the picture of the anterior inferior iliac spine. And this is the CT scan in doubtful cases. This is the anterior inferior iliac spine. It's an apophyseal avulsion injury seen in adolescent athletes as a result of eccentric contraction of the rectus femoris, as we said before. Diagnosis is made with pelvic radiography that shows avulsion. Treatment non-operative in minimally displaced or incomplete cases, but may be operative in older children and pre-adolescents or long the area of displacement. This is the treatment, RICE group, RICE protocol, and open reduction, internal fixation if avulsion fracture or the displacement is more than 3 centimeters. Otherwise, painful non-union may hinder and forces the child to change his career. Differential diagnosis we have: hip dysplasia, leg calves bursitis disease, slipped capital femoral epiphysis, impingement syndrome. The various impingement syndromes about the hip includes femoroacetabular impingement, anterior inferior iliac spine impingement, ischiofemoral impingement, iliopsoas impingement. Many of this will be covered in the next presentation with hip arthroscopy group. This is brief pictures of the CAM and pincer pathologies of the phi syndrome. And this is X-ray, MRI, intra-arthroscopic views. This will be covered in details in the next presentation and next session. Labral reconstruction after osteoplasty, labral tears, small for debridement, large for repair. Sports that require regular rotation of the hips like golf, soccer, hockey, and ballet increase the risk. So do running and sprinting. 75% of cases of torn acetabular ribrum have no known direct cause. Labral tears of the hip are more common in women. Most common associated lesion with labral tears in athletes is chondral lesion, which are usually adjacent to the ribral pathology, chondromalacia, thinning of the cartilage, delamination of the cartilage, or chondral flap tears, full thickness chondral injury with exposed bone, lateral impaction injuries seen with football players. Combined ligamentum teres tear is not uncommon. This is mainly important for prognosis and follow-up discussion with the parents if this child will return to sports or not. MRI is very good, but MRA is marvelous. Ultrasound gives very good results. Gold standard for diagnosis and for treatment hip arthroscopy. This is different pictures for labral tears, and the left one is with ligamentum teres avulsion, and this is the ultrasound picture and MRA picture. I will leave the management in details for my colleagues in the next session. And this is just a picture of the intra-arthroscopic finding. Traumatic subluxation or dislocation of the hip is very rare but very serious, where the ball leaves the socket, and it should be not overlooked. Sports hernia or athletic pubalgia is a painful soft tissue injury that occurs in groin area. It's a problem commonly seen in hockey players but can occur in other sports that require repetitive twisting. The problem is thought to be due to an imbalance of the strong muscles at the thigh, relatively weaker muscles of the upper. First aid is rice and non-steroidal anti-inflammatory. Classic treatment is by, in severe cases, by open surgery or laparoscopic surgery with the help of general surgery. Other than sports-related pathology, this is my last slide. Incidental pathology presenting with groin pain may be skeletal, infection, tumors, extraskeletal, related to bowel, genitourinary system. Careful evaluation of the clinical data and history is very important, and MR images is always warranted. Take-home message: young athletes are not simply minimized adult athletes. Social and emotional factors are different and important. Window of opportunity is narrow. Remodeling is marvelous. Thank you for your attention.
Thank you so much, Professor Wael, for this very interesting talk. We have two main questions. Dr. Ali is asking about the PRP injection, platelet-rich plasma. Of course, this is a very, very important subject, but it's a huge subject.
We conducted a thesis. We conducted a master thesis about this issue, and with the control groups. And the results that we end in is that yearly injection of PRP in the first 48 hours is very beneficial in muscle injuries and in avulsion injuries, especially if helped with drugs that decrease the fibrosis, like losartan or whatever, alpha chymotrypsin or ambizine, something like this. And the follow-up ultrasound shows that the healing tissue, and the MRI also shows that the healing tissue with the PRP group is mainly muscle fibers, while the healing tissue in the control group, which is not received PRP injection, is mainly by fibrous tissue. It's not like PRP injection in osteoarthritis or in some other results that lack evidence, but for the muscle injuries, especially in the early 48 hours, it has very good results.
Yes. The second question from Dr. Gamal Qasim, he is asking, is ultrasound is enough as emergency maneuver for diagnosing acute hip injuries, including physial injuries?
It's first aid. We mean that we are segregating the patients, whether he needs to do further investigation and will go to the hospital to do MRI, or he will just follow up and reassured for 2 to 3 days. So it's used mainly as a filtering procedure or first aid measure, just to segregate the two groups of patients, high risk or low risk.
Yes, sir. Thank you so much, sir. Thank you so much, Professor وائل, for this very interesting talk. وفعلا هو extraordinary talk, يعني انه مش بمجال حضرتك يعني, بس you are trying to stick to your subspecialty, sir. Thank you so much, sir. Our next speaker will be Professor Mazen Samir, Mansoura University. Professor Mazen will speak about reconstructive hip surgery in children with spastic cerebral palsy. Professor Mazen. Professor Mazen.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته أستاذنا. أهلا بيك دكتور مازن بيه.
أهلا بحضرتك. أهلا بيك. Thank you very much, Professor Shahab, for inviting me for this fruitful meeting.
Thank you so much.
And thank you for inviting me, and thank you all. I'm trying to share my okay.
Yes, sir. Full screen, please, sir.
Yeah. Is that okay now?
Yes, sir. Full screen, please, sir. Yes, sir. Yes.
I already did. Yeah.
Thank you, sir.
Thank you. Okay, my dear colleagues and professors, I am now talking about reconstructive hip surgery in children with spastic cerebral palsy. I will discuss pathoanatomy of CB hip surveillance in CB, states indication for varus derotation and/or pelvic osteotomy, enumerate complications of hip reconstruction surgery, and finally, I will present some cases. Hip displacement is the second most common musculoskeletal deformity in CB after equinus deformity of the ankle. Severe hip displacement reduces the quality of life, especially in non-ambulatory CB children. Children with CB are born with normal hip joint. However, spasticity and the contraction of the adductor and iliopsoas muscles cause osseous changes in the femur and the sternum, leading eventually to posterolateral hip subluxation or dislocation. Femur abnormality in the spastic hip include increased femoral anteversion and coxavara, while acetabular abnormalities are high acetabular index and posterolateral acetabular deficiency. Hip displacement as a result of abnormality in proximal femoral growth is now considered not only due to spastic muscle contraction, but also due to lack of functional ambulation and weak hip abductors and extensors. In CB children, the femoral neck anteversion is normal at birth and is increased stepwise from level 1 to level 5 gross motor function classification scale. And the neck shaft angle is also increased in cerebral palsy. However, the radiographic appearance may be falsely accentuated due to increased anteversion. In early childhood, hip displacement is usually silent, and the rate of increase in migration percentage is between 6 to 12 per year for children with level 5 gross motor function level. Incidence of hip subluxation increase gradually and stepwise with increase of the functional impairment as defined by gross motor function classification system, rising from 0 up to at level 1 up to 90% at level 5 with non-ambulatory children. Passive hip abduction in extension of more than 30 degrees is associated with increased risk of hip subluxation and difficulty in perineal care. However, progressive abduction, contracture, leg length discrepancy, or even asymmetrical appearance of the thigh may increase the clinician suspicion for hip pathology. Migration percentage and acetabular index are two hip radiological parameters that are most commonly measured in CB children. CT scan can help in preoperative assessment of CB hips prior to reconstructive hip surgery. There is an interaction between hip surveillance and option for preventive and reconstructive surgery with the goal of avoiding salvage surgery and reaching skeletal maturity with good hip health. The second figure here shows the management pathway of a girl with gross motor function level 4 who had multiple intervention of hip surgery over 13-year period. She got first botox injection and pacing, and then 2 years later undergo muscle lengthening, and then 4 years later she undergo bone reconstruction, and then at the age of 11 done another bone reconstruction, and 1 year later she got scoliosis correction. And here come the importance of hip surveillance in CB hip. The goal of reconstructive hip surgery is to provide a painless, mobile, well-located hip. Reconstructive hip surgery include osseous procedures on the femoral and acetabular side, and in completely dislocated hip capsulotomy may be needed to achieve reduction. Femoral side procedures are almost always performed at the time of hip reconstruction, but acetabular reconstruction is indicated only if there is acetabular dysplasia. As regards the ideal age for reconstructive hip surgery, these surgeries are indicated for children above the age of 6 years with migration percentage more than 40%, and it should be considered in children less than 6 years if complete hip dislocation is present. Varus derotation osteotomy aims at correction of coxa valga and increased femoral anteversion. Adductor psoas release surgery is done at the same setting, shortening of the bone while doing varus derotation osteotomy, and we call it varus derotation shortening osteotomy, create a relative lengthening of spastic muscle across the hip joint, and this is an advantage while you are doing the varus derotation osteotomy. We can fix the osteotomy either with a blade or a looking blade, with a plan to have a final neck shaft angle of 90 degree to 100 degree for non-ambulatory children, and 120 degree for ambulatory children. One stage femoral and acetabular osteotomy should be strongly considered in young children, especially non-ambulatory CB children. Miller performed acetabular procedure on children with migration percentage more than 60%, and also in children who have both migration percentage more than 40 and the acetabular index more than 25. Results from Boston Children's Hospital showed that overall revision rate after varus derotation osteotomy is 37%, and recurrence is seen when the reconstruction is performed earlier than 6 years of age, and particularly in non-ambulatory children. Also, lower annual surgical hip volume were reported to correlate with the increased risk of failure. Hip reconstructive procedures typically result in satisfactory outcome in children with CB, as shown by different authors. Complications of reconstructive hip surgery are reported to occur up to 25% of CB children. Decubitus ulcer and fractures are most likely related to post-operative casting, and so casting is not recommended by many surgeons when rigid fixation is achieved. Avascular head necrosis is also reported up to 11% of patients, and that's why some surgeons prefer to do femoral shortening during varus osteotomy to decrease the rate of this complication. Heterobicosification also reported as a complication following reconstructive hip surgery. In our institute, Faculty of Medicine, Mansoura University, 2 years ago, we started MDCs with the aim to report early result of reconstructive hip surgery including proximal varus derotation osteotomy alone, or in combination with pelvic osteotomy and or open reduction in non-ambulatory children with spastic cerebral palsy. We performed both femoral and pelvic osteotomies under image intensifier. Femoral osteotomy was fixed with a BD-lock plate in all cases. We will present our cases. The first case was a 5-year-old girl with spastic cerebral palsy, quadriplegic, non-ambulatory, showing left hip subluxation with migration percentage of 95% and a stapler index of 45. This is after doing varus derotation osteotomy, DIGA osteotomy, and adductor psoas release. Radiological parameters improved following hip reconstructive surgery with migration percentage is now 0 and a stapler index of 32. After 1 year follow-up, the migration percentage is increasing, but the hip is still contained. Second case, 6-year-old boy with spastic cerebral palsy, quadriplegic, non-ambulatory, showing left hip subluxation with migration percentage of 62 and a stapler index of 36. Also, we did for him varus derotation shortening osteotomy, DIGA osteotomy, adductor psoas release. And this is 6 months follow-up. Radiological parameter improved with migration percentage 0 and stapler index of 25 degree. Third case, a 5-year-old girl with spastic cerebral palsy, quadriplegic, non-ambulatory, showing complete right hip dislocation and the stapler index of 25 degree. This is after doing varus derotation, shortening osteotomy, and adductor release. We did do for her. We didn't do DIGA osteotomy. However, she got femur fracture 6 months after the surgery, and she underwent fixation, used locked plate. And now this is her last X-ray we have up to now, 6 months after last fixation, and with migration percentage of 35, and we will do close follow-up of hair. So finally, take-home message: hip displacement is the second most common musculoskeletal musculoskeletal problem in children with cerebral palsy. Severe hip displacement reduces the quality of life in children, especially non-ambulatory children. Reconstructive hip procedures are indicated for children above the age of 6 years with migration percentage more than 40%. One-stage femoral and stapler osteotomy typically result in good outcome in children with CB. Thank you very much.
Thank you so much, Professor Mazen Samir, for this interesting talk. We have just one question, sir. Psoas tendon, do you prefer release or lengthening?
Actually, I'm just doing a release of it. I didn't do lengthening, and sometimes when I'm doing the when I do shortening of the femur itself, I sometimes try to go making the osteotomy, I didn't remove a wedge. So when I make a osteotomy, I just try to elevate the iliopsoas from the lesser trochanter itself.
Yes, sir. Another question, sir, from Dr. Mukhar. When you open the capsule for reduction?
Up till now, I did not do that. All the cases was reduced while doing varus derotation osteotomy and adductor release. We didn't need up till now to open the capsule, but we bought it in our mind in every case.
Yes, sir. Thank you so much, sir. And thank you for your participation, sir. Thank you so much, sir.
Thank you.
Our next speaker will be Professor Mohammed Laklouk from Minya University. Professor Laklouk will speak about a very interesting subject, S-shaped capsulotomy in DDH, wide exposure of the hip joint and hip layer capsularity. Professor Mazen, would you please stop sharing, please, sir?
Yes, I will do that. Thank you.
Thank you so much.
السلام عليكم ورحمة الله.
عليكم السلام ورحمة الله وبركاته دكتور محمد.
الأول بنشكر سعادتك على المجهود الغير عادي ده والصبر على المجهود ده. ربنا يكرمك بيه ويجازيك خير إن شاء الله.
ربنا يبارك في حضرتك يا أستاذنا.
الصورة واضحة كده؟
واضحة يا فندم. يس سير.
بسم الله الرحمن الرحيم. هنتكلم النهارده إن شاء الله S-shaped capsulotomy and surgical treatment of DDH.